Hello and welcome to another edition of Professor Speaks. My name is Alex Hernandez. Alongside me, as always, is Dr. Craig Stern. And before we get started, we wanted to wish you a happy holidays, and we hope it's been a safe and fun year for you. And we want to wish you great blessings and all this good holiday stuff for the next 2018. So, sorry to bring you down a little bit, but we're going to talk about how it's been a roller coaster of a year for healthcare. There's been some instability, there's been some uncertainty. We have seen some large insurers become even larger. We have seen healthcare costs continue to increase, and worst of all, we have seen the opioid epidemic continue to grow. But there has been some positives. We have seen some hospital visits decrease. We have seen the overall population health increase, and but we want to look back on 2017, and we want to.
Alex, can I
Oh,
interrupt
go
for
ahead. Go ahead.
Yeah. Um, Aside from all the issues and aside from all the politics, there have been things that have happened that have been positive, and we should highlight that.
Okay.
Whether it's true because of the Affordable Care Act, whether it's true because they were going to happen anyways,
Right.
or the healthcare system was doing it, one of the goals of all of this was to get more people insured so that they would have health care, because both the cost and the utilization was breaking the bank with regard to the country as well as health care.
Right.
There have been a significant increase in the number of insured population. That improved dramatically. Number two is the number of hospital admissions dropped. The length of stay of hospital admissions dropped.
Right.
Emergency room visits dropped. Hospital readmissions dropped.
Mm-hmm.
Those are the typical measures that people use to say that things are going well or better in the community.
Right.
So those are a few cases, besides the fact that there have been some significant improvements in lifetime improvement with regard to cancer. There's been some significant improvements in cardiovascular disease.
Right.
At the same time, there has been, because of our lifestyle, and it's not just the United States lifestyle, it's true across the world, people are getting fatter.
Lack of exercise.
They're not watching their diets, etc. So there's the good and the bad news with regard to that, but there are multiple metrics to show that things improve. So we should at least acknowledge that there has been some good.
So not a complete downer. And I was going to mention, like, as a result of the ACA, a lot of insurers are, a lot of the population are insured, but that also brings us to this new tax bill that we talked about last week, where some of that uncertainty of those people that are now insured may not be insured in the future. And that leads me to my first topic, which is the uncertainty in the healthcare space. At the beginning of the year, correct me if I'm wrong, that there has been some mergers, or at least they wanted to merge, from the top 5 insurance companies. Am I correct?
Yeah. You're absolutely right.
Then it's CVS, Aetna, WellPoint, United. The fifth one is escaping me. But regardless of that, they were going to become the big three. Humana, that's the one.
Right.
They were going to become the big three. And that, I believe, they covered 90% of the insured population.
Yeah, but let's stop for a minute.
Yeah.
I understand where you're going, and I think it's important, Alex. But the question is, why are people consolidating? We're in a world of significant uncertainty where people don't know what's going to happen.
Right.
So one of the issues that is going on is to try and bulk up so that areas that are not as profitable bulk up with those that are profitable, and to try and squeeze some of the inefficiencies out of the system. That's number one.
Right.
Number two is the whole concept of too big to fail.
Right.
If I'm bigger, then it's harder for any of these things to fail, because if I pull out or there's a problem, then it's going to create a significant amount of rippling that goes through the system to deal with it. And the third thing to deal with uncertainty is doctors have complained that they've lost a lot of control, and to a degree they're right. Health plans, insurers, providers like pharmacy, CVS, and the rest have taken over a lot of those roles, so that physicians and 80% of all physician practices today are owned by corporations or hospital corporations. So
Okay.
the issue where doctors used to control everything that went on in healthcare has eroded to a significant degree, and there has been a significant amount of big corporate issues that are trying to run that in a more profitable, efficient, quality producing way. And effectively, that means that it mitigates the cost of doing quality care, ensuring that everybody is giving patients a minimum standard of care, and the rest harder to do when everybody's broken up,
Right.
easier to do when you're bulked up over big things. That doesn't say that everything about it is good. It just says there's a reason why these things are happening.
So doctors feel more restricted because they can't really go this route because this company says it costs too much to go
Yes,
that route.
exactly.
Right.
Exactly.
And another part of the uncertainty in healthcare would be the health plan premium rates. They're going up. They keep going up, and that's been a problem. I guess they've blamed it sort of on the ACA. Am I wrong on that?
No, they are.
They are.
But I think it's fair that we at least put this in the context.
Right.
Whether you're a Republican, a Democrat, or just somebody trying to survive, there's a lot of news here or statements that are just plain false.
Right.
Within the Affordable Care Act, about 2/3 of it was working and leading to some of these things that we've indicated have improved overall health care.
Right.
A third of it wasn't working. So it clearly identified that something had to be improved. No question about it.
Right.
But this constant refrain that it's failing and all the rest of this stuff is nonsense. It wasn't. But in all cases, in all government programs, they started 5 years later, you have to change it, et cetera.
Right.
And I've said this before, the Medicare has changed 11 times since it was instituted.
Right.
Medicare Part D has changed, I'm not exactly sure how many times, but probably 5 to 7 times it's changed.
Right.
So government programs tend to be, by their very nature, things that you started, it's an experiment, you see what's working, you see what isn't working, you fix what isn't working, and you move on.
Makes sense.
And but today, the polarization of politics has made it where it isn't something where everybody consensually negotiates and tries to come up with a common solution. It's where everybody stands a strong ground and won't move. From a healthcare standpoint, that harms us because it means that you can't get a better solution. You can only get extreme solutions. And then if one doesn't work, then you're dealing with fixing. So in some ways, respectfully to everybody, politics is in the way of what goes on, and in effect is standing in the way of the people who know what to do, getting in the way of what needs to be done.
Thus overcomplicating everything.
They do. They do.
And something else we've seen in 2017 is the chronic and pre-existing condition. We've seen that topic come up multiple times, especially when the ACA was first enacted. They brought up the idea that people were no longer going to be talked out of or pushed away for having a chronic or pre-existing condition. Now it's all in the air. So how do we go forward with this?
Well,
we just don't know what's going to happen.
The whole issue of pre-existing conditions is really something that's existed forever, and that is there are people who have chronic health conditions, and in effect, people over age 65 have more chronic health conditions than do younger people. Okay,
Right.
The largest cost, the largest concern for people between the ages of 20 and 40 is childbirth.
Okay.
A happy situation coming in and a happy situation coming out, hopefully.
All right.
However, chronic conditions, diabetes, hyperlipidemia, cardiovascular disease, heart attack, stroke, all of those are chronic diseases that are now known as pre-existing conditions, whatever they are, and there's a lot of them.
Right.
Those are the things that people are concerned about, and what do you do about it? We're always going to have chronic conditions. We're always going to have to treat it, but now people are going to have to pay more attention, and it's not just about doctors. not just about nurses, not just about pharmacists, not just about hospitals. Now people have to be actively involved because the cost is shifted, where a significant amount of that is shifted to the individual patient.
Right.
So the patient now has to be a better purchaser. The patient needs to ask the question, what's the value of doing a particular test versus not doing it, or another alternative test?
Right.
What's the value of this drug versus alternative drugs? Is there a cost savings? Or is there a generic substitute? Are there things that are available that I can get the same benefit for it? Patients are going to have to get involved and be better purchasers. Now that mantra sounds good. It was true when they started managed care, but at the same, and that's been going on since 1969 or so. So it's been a long time. But at the end of the day, now costs are rising significantly, and people have to pay attention to it. And then they're going to have to start demanding what they want with regard to healthcare, both public healthcare and private healthcare, because private healthcare frequently rides the coattails of what's happening on the public side and what they get.
Of course, you got to manage your profits and losses in that case.
Right.
And we can expand on that subject because it's going to come up again in 2018. But I want to move on to CHIP, which is also going to be moving on to 2018. They have done nothing about CHIP, and I believe it's due to expire for next year.
It is due to expire. It's been going on for a very long time. We talked about it in a prior conversation.
Right.
This is unfortunate. There's about 3 million kids in the United States that need this kind of care, whether it's cancer care, whether it's just general care, or otherwise, kids need it. It started in Congress at the time of Edward Kennedy and pushing for this particular program. So it's not new. It's not something that happened yesterday. It's been going on a long time. It's unfortunate that Congress has placed that priority low and not dealt with it. Clearly people need to address whether they think it's important and demand that something be done. If not, we need to find other approaches of what to do with this, because there wasn't any approaches, so CHIPS came in order to try and address it. But now we need to find other ways to do it. We've talked about it in the past, charity situations, foundational issues, giving money. Obviously, corporations are getting a lot of money. There may be some opportunities to put some of that money into care for children. But one way, you got to do something.
Yeah.
You can't just allow these kids with these ever more increasing costs of therapy to just be left on their own accord. It's not fair.
And the uncertainty doesn't stop there. It keeps going and going. There's so many questions that need answers, and nobody seems to be addressing them at all. And but we got to move on to the next topic, which is the cost of these medications, both standard and specialty. There seems to be a lack of transparency in all these costs, and how does this affect the way doctors administer their care? All this lack of transparency, doctors are restricted. They can't go a certain route because they're worried about what the insurers are going to say.
Right.
How do we address this?
When you talk about transparency in healthcare, what that means is rebates, which means that it costs you this much, but if you can get manufacturers to give you a rebate, a coupon, green stamp, whatever, so that it'll lower the cost, that's what healthcare thinks about it. They also think about the cost, and the cost meaning along the way, everybody is involved, whether it's the manufacturer, whether it's a health plan, a pharmacy benefit manager, physician, pharmacy, etc. Everybody's taking a piece of the action.
Right.
The transparency problem is, where is that money coming from and how do I address it? On the patient side, the question is, what is this going to cost me? Because more of this cost is being shifted to the patient. Well, on the transparency side, on the medical side, there isn't transparency. It isn't quite clear how people are addressing rebates, how much you're going to get, what drugs are being approved or otherwise. There's a lack of transparency. In the case of health plans, PBMs, manufacturers, there's an argument going on over who is the one that is actively increasing costs and where is it happening.
Right.
The reality of it is it's happening everywhere and everybody is putting their ladle into the stream in order to take something out of it.
Right.
But whether it's costs that are increasing for brands from manufacturers, whether it's generic cost spread under the maximum allowable cost that happens for pharmacy benefit managers and health plans, whether it's pharmacies and the profits that they make. Many times they'll say there aren't any profits in it.
Right.
And physicians, based on whether they're in network or out of network, as to how they're going to address. Those are real problems. And what people are asking today is, effectively, I want to know what the cost plus is, meaning what is the cost, how much are you adding to it, and then I'll decide whether that's a value or not. It's kind of like buying a suit and saying, I am willing to pay an additional X number of dollars to buy the suit, or I'm willing to buy it because it was made by some famous couturier.
Right.
But I'm not willing to pay that kind of amount, and so I'll get a cheaper suit or one that isn't made by a fancy guy. It's that kind of a problem that we're addressing today. What do people do about it? Well, number one is they need to demand from everyone, government, federal government, state government, what they're going to do about it to control the cost. On the other side, they need to make value choices. How big a deal is this to me, and am I willing to do it? There's just recently a new drug that came out for a particular retinal problem so that people can't see, mostly in children.
Okay.
It's a new drug. It effectively is a genetic drug that modifies the genetic problem that causes this retinal issue, trying to be simple about it.
Right.
The drug is going to cost $1 million.
Oh my
So clearly you
Wow.
have children, you want to take care of them, you want things to be improved, but by the same token, average income in the United States is about $59,000, and now you're telling them they're going to pay $1 million in order to deal with that. Good news, there's only about 300 people or so that are affected. Bad news is it costs $1 million.
Good news is only 300 people. Bad news, it's still 300 people.
Yeah, exactly.
Yeah, and it's like most of this lack of transparency comes because they can do it. And I know there's a couple of senators out there that want this transparency, but so long as they can be withholding information, they can block off the transparency, is they can shift blame to somebody else.
Well, you're right. You're absolutely right. What we're in a world today is where pharmaceutical companies are bad, patients are good, pharmacy benefit managers are bad, depending on whether you want the argument between the two, one way or the other.
Right.
And then everybody else is trying to take a piece out of whatever this is. This is really more of a purchasing decision. Somebody buys a Mercedes, a Lexus, because they have the money and they want to have the ride. Somebody else buys a Prius because they want to have the ride, but they don't necessarily want to have all of the
They don't need the luxury.
plus luxury stuff that goes with it.
Right.
We need to realize that a lot of this is a decision that is made based on care. What managed care has done, what population health has done, regardless of what's happening in politics, is to try and set up a standard where there's a minimum standard of care for everybody. And then whatever else you do is predicated on that. In Europe, they restrict a kidney for someone who's over a particular age. They restrict a liver transplant to someone who is over a given age, has a history of alcoholism or things like that. United States, that's anathema. But as the costs increase, people are going to have to start to make decisions.
Yeah.
And those decisions are not anti-anybody. They're not anti-PBMs, they're not anti-pharma, they're not anti-health plans, they're anti-doctors, pharmacies, or otherwise. They're just trying to decide how much you're actually going to pay.
Right. Right. Okay, well, let's move on to another topic for 2017 also. We want to talk about excuse me, the access to care. Now, we've talked about this in the past where CVS announced that they were going to do next day shipping, right? and they articles would say that it's as a result of Amazon potentially coming into the drug market or the pharmacy market. So, talking about the retailization of pharmacy, right? And it's not just pharmacy; it's also other forms of care, but mostly pharmacy because we are the number one buyers or number one consumers of prescription drugs in the world.
Mhm.
So, let's talk about the use of, or the real retailization that we should look forward to in 2018. It's probably going to happen.
Well, it already has happened.
Right.
The retailization you're talking about, Alex, is not just drugs. It has to deal with, for example, these minute clinics or care clinics that are available in pharmacies,
Mm-hmm.
where they have a nurse practitioner or a mid-level who sees patients for a particular problem, whether it's
Right.
a upper respiratory problem, whether it's a urinary tract infection problem, whether it's whatever it is, blood pressure, whatever. And they're seeing for a particular problem. If they write a prescription, there's a pharmacy right there. So access is there.
Right.
Service is there because you can see them right away. You can get service right away rather than sitting in a doctor's office for an hour or more trying to deal with that, or going to an emergency room or something like that. So it's less costly. There's easy access because pharmacies are around and they have these clinics, and because there is a lower price for all of that. That retailization has taken it away from doctor practices.
Mm-hmm.
As one doctor in Montana said to me, I used to be able to walk through the day with my eyes closed that 75% of the time. I could treat anything and I could deal it in my sleep. Now, on the other hand, 75% of my practice is really acute. So it took it away from doctor practice, put it into the retail sector,
Mm-hmm.
and that needs to be integrated with all healthcare systems. Sometimes it's integrated, sometimes it's not.
Right.
It needs to be integrated in what goes on with regard to insurance so that the insurers know what's happening. Like if you go to a health fair and you get a flu vaccination,
Right.
it isn't that information isn't transferred, so the health plan doesn't know, your doctor doesn't know that you got the flu shot.
Right.
So that information needs to be integrated in what goes on. But then the other larger issue is, if you will, the triage of patients. There's some patients that are well that really don't need anything. Maybe they need some sort of an over-the-counter drug, or maybe they need nothing.
Just like an Advil or something.
Just to identify, you don't have anything, you'll be fine. There's another part of the population, about 2.5%, that is really severe.
Right.
And they're not going to be handled in the retail sector. They have to go see a doctor, an emergency room, hospital, whatever. And then there's everybody else. So what's going on here is trying to deal with the population by triaging the ones who are well, triaging the ones who are have a pre-existing or chronic condition, making sure that they stay stable so that they're not showing up in the ER and the rest.
Right.
And then the severe ones, making sure that they get care as soon as possible, so you jump on the problem and deal with it rather than waiting for it to be overly horrible, or as we call it, train wreck. And now you have to deal with what that problem is. That's really what's going on.
Right. And it seems like it's going to be, it might be a compliance problem somewhere down the road too, right? With easy access to some of these other drugs or adverse drug interactions, so on and so forth.
But you need that data integrated, because if you don't have it, you don't know. It looks like a big problem, but it may have already been addressed in another way.
Right.
So the retailization is an important move. It's been important and it's changed things.
Mm-hmm.
But at the same time, you have to look at this as a multi-dimensional issue. There's retail to deal with non-serious problems. They may be acute, but they're non-serious. Places that are traditional, like acute care hospitals and ERs, to deal with really serious, urgent, emergent issues.
Right.
And then how do you deal with everybody else in keeping them calm? Today, things have improved. whether they will improve or not in the future, that's part of the uncertainty. We don't know, and that's why people want to know about transparency, because it's uncertain, and if I have to make a decision, how much is it going to cost?
Of course, of course. Well, in the instance of time, we want to talk about something else. Some of these serious conditions that have come up or have been gradually increasing over the years, which is opiate abuse. You mentioned earlier the weight gain of the population, antibiotic overuse, and we also want to talk about medication overuse in the elderly. Um, some thoughts over you.
Well,
Yeah,
yeah. The opiate abuse problem is one that the healthcare system created.
of course.
And
We've
it was
talked
too
about it in the
easy.
past.
Yeah, we have. We gave out prescriptions too freely with too many medications, and we created the problem. Now we have to solve it. There are standards. The CDC, Centers for Disease Control, have come up with standards. There's method, but now everybody has to get on board in order to deal with it.
Right.
Because it's too easy. You come to me as a patient, and I want to solve your problem, and the easy thing is write a prescription and get you out of here. You'll be happy, I'll be happy, and life is good. But that's not the solution to the problem.
Of course.
The second issue is antibiotic issues. We created that problem too. From an empirical standpoint, people came in, didn't want to take time to do laboratory testing about what was the bug, what did it cure, etc. So rather we did empiricism, and we dealt with very broad antibiotics, and we created a problem. Now we have to address it, because as people get older, they're resistant to many of these drugs. They used to be able to easily kill common bacteria. We now need to be able to address that. And there's now antibiotic stewardship programs going on in hospitals, some that are occurring on the ambulatory side. We know because we're doing some of that stuff. Mm-hmm. That we're doing some of the opiate stuff in utilization review, alerts to doctors, peer-to-peer counseling. And so we know about that.
Right.
Issues with regard to patients being overweight, that's a prevention mechanism, and it's an individual one. People have their choice. If you don't choose to do something about it, then you have the consequences, and the question is, how are you going to address that? So there's the
how do you educate an entire population?
Exactly. There's the patient issues with regard to prevention and wellness, if you will.
Right.
There's medical created problems like opiates and antibiotics that we need to address and convince the public that what we did before was the wrong thing. Now what we need to do is the right thing.
Mm-hmm.
And then finally is this whole issue of the healthcare system gets more and more complex because there's more and more choices. So it means that not just that general government or institutional or groups that are involved with a particular disease get out and educate. Every individual healthcare person, me, you, every doctor, every nurse, everybody needs to get into the practice of not just pontificating about what the issue is, but what needs to be done so that people hear from the experts what is it that needs to be done, how they're going to fix it.
And then the next trick after that is getting people to listen to you as you lecture to them.
Yes, yes. Which is like this.
Exactly. So as you can see, we got a lot of work to do in 2018 and a lot of things to look forward to as well. So before we go, we just want to wish you all a very happy holiday. There was plenty of other stuff that we went over in 2017. Feel free to go back to our videos. We have an entire archive of it, Facebook, YouTube. We save all the videos. And feel free to message us. Give us a message. Let us know if you have any comments or anything specific. Just please feel free to contact us. We will be off for the next 2 weeks, enjoying our holiday as well and New Year. And we will see you in the new year, and we'll have plenty more to discuss.
Happy New Year, happy holiday, and to everybody a healthy, a happy, hopefully a peaceful, wonderful new year.
Yep, and that's us signing off for 2017, and we hope to see you in 2 weeks.